Psychopathology Revision. What do you need to know for the psychopathology abnormality topic? Well, you need to be aware of the 4 definitions of abnormality, the characteristics, so behavioural, emotional and cognitive, of phobias, depression and OCD, how we can explain these 3 mental health disorders, so behavioural explanations of phobias, cognitive explanation of depression and the biological explanation of OCD, as well as how we can treat these 3 disorders. So the 4 definitions of abnormality then. Statistical infrequency is when an individual has a characteristic that is less common than most of the population. So they are seen as abnormal if they have certain behaviours or traits that are statistically rare within the population. So for example, they may be more or less intelligent than most of the population, or they might be judged as being more depressed than most of the population. So let's look at the evaluation. There are some strengths to this. There's real life application. So it allows us to judge how severe an individual's symptoms are in comparison with statistical norms. So we might be able to judge whether they have mild or severe anxiety, which might determine what type of treatment we offer them. However, it is culturally relative. So the standards in which you use to judge an individual are based on one group's statistical frequencies. So therefore it might not be applicable to all groups or cultures. So for example, if we were judging someone's height as being abnormally tall or abnormally small, the average height of one country might not be the same as the average height of another country. So it might lead to a misdiagnosis. The second definition is deviation from social norms. So this concerns behaviour that is deemed as being abnormal if it deviates from the unwritten accepted standards of a society or community. So there's some real life applications of this, so it helps us define conditions such as antisocial personality disorder. Again, however, it is culturally biased. So some social norms can differ between cultures. So there isn't one set of social rules that applies to all different cultures. So for example, in our culture, we might find that it's an unwritten rule that men shouldn't necessarily wear makeup. However, in other cultures, it may be perfectly acceptable, particularly within certain tribes, for men to put on war makeup when they go into battle. Failure to function adequately. So this is when mentally healthy people are judged as being able to cope with life within certain limits. A person is deemed as being abnormal if their behaviour stops them having daily function. So for example, if they can't live their life adequately and meeting the accepted understandings of how we should live our life. Once again, there is culturally relativism. So cultures have different expectations about how people should behave. So what we might see as an irrational and unpredictable might not be judged so in other cultures. Also, is abnormal behaviour really maladaptive? So remember, maladaptive means not suited to the environment. It may be that the person actually gets attention from that behaviour. So in the past, transvestitism was considered a psychological disorder, but really is that as maladaptive as first thought? Deviation from ideal mental health then. This is when abnormality is seen from not meeting the criteria for a positive mental health. And this is based on Jehoda's characteristics. So it includes a positive attitude towards themselves, an accurate perception of reality, the ability to resist stress. However, a negative of this is that it's very subjective. The characteristics measured, such as self-esteem and self-actualization, are very difficult to measure. They particularly use questionnaires which are subjective and not always valid and reliable. Once again, there is a culture issue. So measures adopt a adopt a Western approach to normality. So it's what a Western culture would view as being normal. Using these criteria or characteristics, it might be that we mistakenly diagnose someone from another culture as being abnormal. So, a really easy evaluation point to try and minimise the amount that we have to remember is to remember that all of them are culturally biased. They all have an issue with their culture. Phobias. So we're looking at the characteristics of phobias. So phobias are an anxiety disorder. Whilst it is normal to be afraid of certain things, fear is not necessarily linked to phobia. So if you're frightened of something, it doesn't necessarily mean you are phobic of that stimulus. A fear only becomes a phobia when it negatively impacts on a person's everyday life. So the behavioural characteristics then, they may have avoidance, so they will alter their behaviour to avoid a feared stimulus or situation. So it makes it really difficult for them to go about their daily life. So they may try to escape a feared stimulus or situation if it's encountered. So they might not go to certain places, they might take a different route to work if in case it involves going over a bridge, if they're frightened of heights. They also have panic when they come into encounter with that feared stimulus. So they might be crying, generally restless, easily startled, they could even be screaming, or they might freeze. So panic will be a result of seeing that feared stimulus or situation. The emotional characteristics then. So anxiety, which is an unpleasant state of high arousal, so it prevents them from feeling relaxed and makes it difficult for them to experience any positive emotions. And there's also a feeling of dread when they encounter the feared stimulus. Cognitive. So they hold irrational fears and beliefs about the stimulus and situation. So it's an irrational fear. It's not within proportion of what might happen. Also, they have selective attention. So they find it hard to concentrate because they are preoccupied with the anxious thoughts. So they might find it hard to look away from the feared stimulus. So imagine you were frightened of spiders and you knew there was a spider in the room. You would find it really difficult to concentrate on anything else, and you'd be constantly thinking about where that spider is in relation to you. And also you might be constantly on the lookout for where that spider is in the room. So how can we explain the development of phobias? The behavioural explanation says that it's a two-process model. This means that it firstly started via classical conditioning, and then it is maintained via operant conditioning. So both of these processes are needed to explain why the phobia happens in the first place and then why it continues to happen. So classical conditioning is how the phobia has developed, how it started. So this happens through association. So a neutral stimulus is paired with an unconditioned stimulus that results in a conditioned response being present when the neutral stimulus is encountered. So for example, if you were younger and you were at a party and then a balloon exploded in your face, you might then develop a phobia of balloons because you associate that balloon with getting upset when it went bang in your face when you were younger. If we relate it to some research then, Watson and Rayner's study on little Albert, they paired a neutral stimulus, which was a white rat, with an unconditioned stimulus, which was a loud noise. So they banged a metal bar behind his head every time he saw the rat. And after making this pairing of the rat and the loud noise, which made him upset, he produced a conditioned fear response to the rat by itself. So it demonstrated that fear can be learnt through classical association. Phobias tend to be maintained through operant conditioning. So this might be why an individual continues to feel fear or why they avoid the feared object in the first place. So avoidance of the phobic stimulus reduces the fear and anxiety. So that is an example of negative reinforcement because they are removing or escaping that unpleasant stimulus. So if someone had a phobia of dogs, they would generally avoid dogs to remove the anxiety that they experience when they encounter one. Therefore, they are negatively reinforcing their phobia of dogs. They also might find that when they have a panic attack during their encounter of their phobic stimulus, they might gain attention, which could be rewarding. So that is positive reinforcement. So let's look at the evaluation. So the fact that the behavioural explanation leads to effective treatment, so the behavioural treatments tend to be quite effective, would suggest that the behavioural explanation in itself is accurate. Because if they're able to treat the problem, then it suggests that we have worked out the cause of phobias. Also, we've got some supporting evidence. So it was found that individuals who had a severe fear of driving, over 50% of them had been in a car accident, which would suggest they had learnt the fear of driving through the association of being in a car accident, supporting the idea that we have learnt phobias. However, it was found that only 7% of spider phobias recalled having a traumatic experience with a phobia. So that could mean that some phobias have an evolutionary origin. So it might be beneficial for us to be actually frightened of certain things, such as spiders, snakes, because they could have killed us in the past. Other explanations are completely ignored and they aren't taken into consideration. So it doesn't take into account why a person might not have had a traumatic experience with a phobia, but they might have learned it through social learning theory, so observing a parent with a phobia. Also, Buck found that agoraphobia doesn't support the model, so people seem to be more focused on the positive aspects of safety rather than avoiding the phobic behaviour. So that doesn't support the idea of operant conditioning maintaining the phobia. Behavioural treatments of phobias. So you need to be aware of systematic desensitisation and flooding. Systematic desensitisation is a type of behaviour therapy that is based on classical conditioning. So the phobia is broken down into smaller stimulus response units. So that involves a construction of the hierarchy of fears, there is training in relaxation, there is a graded exposure to the feared stimulus, and there is homework for the client to work through. It consists of 3 main stages. For the first stage, they are taught relaxation techniques, such as deep muscle relaxation, breathing techniques, and meditation. This is done so that they can use these techniques later on during the therapy. Next, together the client and the therapist work to create their hierarchy of fears, starting with the least fearful situation, working all the way up to the most feared situation. Thirdly, they work through the hierarchy of fears, starting with the least feared scenario. If at any stage the client becomes anxious, they are encouraged to deploy the relaxation techniques they have learnt. Once they become at ease and relaxed, they move on to the next stage, so they gradually work through the hierarchy. It is hoped that when they reach the top of the hierarchy, that feared stimulus has been extinguished. They stop feeling the fear. It can be carried out using the imagination, so in vitro, or it can be carried out in reality, so in vivo. So evaluation of treatments. When we evaluate the treatments, think about whether they are an effective form of treatments or whether they are an appropriate form of treatment. So, it is quick to administer and requires less input from the patient compared to other psychological therapies such as psychoanalysis, meaning that the training is more accessible to people and people are more likely to continue with the treatments, suggesting that it is an appropriate treatment for phobias. It is also less traumatic in comparison to flooding, so it's a more gentle step-by-step approach, suggesting that it is a more appropriate form of treatment for phobias. However, it is not effective in addressing phobias with an evolutionary origin. That's because they haven't been learnt through experiences, they haven't been conditioned in the first place, therefore they can't be removed through counter-conditioning. The second behavioural treatment you need to be aware of is flooding. So this is where the feared stimulus is confronted directly. So instead of the graduated step-by-step approach of the hierarchy is done directly. So there's no relaxation techniques and there's no gradual build-up. Flooding sessions tend to last between 2 to 3 hours, and the patient is kept in the situation until the anxiety they feel at first has worn off. Once they realise that nothing bad has happened to them during this time, the fear should be extinguished. So it is effective. So it was found that flooding was more effective than systematic desensitisation at treating phobias. However, it can be highly traumatic for the individual, and the patient may quit the treatment because of this. So that reduces the effectiveness of the therapy, or suggests that it might not be appropriate to all people. So depression. Depression is a mood disorder. The behavioural characteristics consist of activity levels. So sufferers of depression have reduced levels of energy, so they often appear quite lethargic, which could affect their work, education and social life. They also have disruption to sleep and eating behaviour. So they might have reduced sleep, so insomnia, or they might have increased sleep, so hypersomnia. Their eating habits may also change, so they may increase their appetite or decrease their appetite. So you may see a person with depression either gain weight or lose weight. They may also have aggression and self-harm. So sufferers of depression can often be irritable and can become verbally and physically aggressive. The emotional characteristics, so anger is a common trait, so they can be directed towards themselves or towards others, and sometimes that emotional characteristic can lead to self-harming behaviours. They have lowered mood, so patients often describe themselves as being empty or worthless. They also have lowered self-esteem, so sufferers of depression tend to report reduced self-esteem that can be extreme, and some sufferers describing this a sense of self-loathing about themselves. The cognitive characteristics then, they have poor concentration, so they tend to be unable to stick to a task or find it difficult to make decisions compared to their normal behaviour. Attending to or dwelling on the negative, so they're more inclined to pay attention to negative aspects of a situation and ignore any positive aspects. They may also be biased towards recalling unhappy events in comparison to happy ones. They have absolutist thinking, which is sometimes referred to as black and white thinking. So when they see a situation as being unfortunate, they tend to see it as an absolute disaster. Cognitive explanations of depression. So it is a person's cognitions that creates a person's vulnerability to depression. So for example, the way they think. So we have Beck's negative triad. So Beck believed that a depressed individual feels the way they do because of their thinking, and their thinking is biased towards negative interpretations, so schemas. These negative schemas have developed as a result of traumatic childhood experiences, such as parental criticism or rejection by others. So the negative schemas form the negative triad. So they concern the self, so I'm unattractive, the world, even my boyfriend hates me, and the future, I'll always be unattractive. Ellis's ABC model. So this is where irrational thinking is the source of irrational beliefs. So the three most important irrational beliefs are: I must be improved by the important people, I must do well or I'm worthless, and the world must give me happiness. So people who hold this belief may become depressed. The model claims that a disorder begins with an activating event, so for example failing an exam, which leads to a belief about why this happened. This belief can either be rational, so I didn't prepare, I didn't revise enough for my exam, or it can be irrational, I'm too stupid, I'm too worthless to pass my exams. So this leads to a consequence. Either it's an appropriate consequence from a rational belief, so I'll do more revision for my next exam because I didn't revise well enough, or an inappropriate response, so feeling depressed and worthless because their belief was irrational. So Evans et al. Found that depressed people have a tendency to maladaptive thoughts, and the more they hold, the more severe their depression was, which suggests that they do have a negative thought process supporting the ideas of the explanation. There are practical applications, so treatments tend to be quite effective for CBT, therefore it would suggest that it is based on a valid explanation. However, it has been found that depressed individuals actually give more accurate estimates of the likelihood of a disaster than normal controls, which suggests that they see the world for what it really is, and people without depression see the world as in this rose-tinted view. So this was referred to as a sadder but wiser effect. Also, it's unclear which comes first, so it could be that depressed people develop these negative ways of thinking because they are depressed, rather than it's the depression causing the negative thought processes. So it's difficult to establish cause and effect. We can't say that this causes this because there is just an association. Also, it blames the patient for their depression, so it completely ignores any biological factors. So it has actually been found that depression is linked to low levels of serotonin, which is ignored by this model. The cognitive treatments of depression. The aim of the cognitive behavioural therapy is to encourage them to develop strategies to change their irrational thoughts into ones that are more positive and rational. So they correct these unrealistic ideas through cognitive restructuring. And the therapist supports the patient through CBT until the patient's thought processes have become rational and positive. So rational emotional behavioural therapy, REBT, was developed by Ellis and is based on his ABC model. So it helps people to change their thought processes by replacing their irrational thoughts with rational ones. So it's believed that these changes can lead to a more positive reaction and a more sociable behaviour. So they're often asked to complete assignments or homeworks in between sessions. So it could be including asking a person out on a date that they've been afraid of doing so, or it could be looking for a new job, asking friends to tell them what they really think about the person, and so on. It is vital for testing their irrational beliefs against the reality and allows them to put new rational beliefs into practice. So the therapy involves challenging the negative thoughts, and change is achieved through disputing their beliefs. So they dispute their beliefs in three ways. There is logical disputing, so they ask themselves if the way that they are thinking actually makes sense. Empirical disputing, so they're asked to see whether there's any evidence or proof that their thoughts are accurate. And pragmatic disputing, so they ask themselves whether the way that they are thinking is actually helpful for their life. So, once again, we have effective treatment. So March compared the effectiveness of CBT with antidepressant drugs and a group that had a combination of the two. So after 36 weeks, 81% of the CBT group and 81% of the antidepressant group had improved, and 86% of the combined group had significantly improved, suggesting that CBT is an effective form of treatment. It also leads to long-term success. So Holon et al. Found that patients who were withdrawn from CBT were significantly less likely to relapse in comparison to patients that withdrew from drug treatments, suggesting that it is an appropriate form of treatment because it leads to a long-lasting effect. However, it might not be appropriate for everyone because it is time-consuming. So CBT requires a lot of time on behalf of the client, which may not suit everyone. So individuals may not have the motivation needed to complete the treatment, especially if they have depression. It's not suitable for all, so treatments may only be effective for people who have good problem-solving skills and insight into their own behaviour and willing to spend time on the problem. So if a person doesn't meet that criteria, it might not be an effective form of treatment for them. It also depends on the therapist, so it's only effective when the therapist is experienced. Patients whose therapist was still in training may actually be better off on drug therapy. So OCD. OCD is a serious anxiety-related condition where the person experienced frequent and intrusive thoughts, which then followed by compulsions. So obsessions are the cognitive part of OCD and the compulsions are the behavioural aspects. There's also emotional aspects to it, such as the anxiety. So behavioural, the compulsions are the repetitive physical behaviours that rituals that take place that are performed to help relieve the anxiety caused by the obsessional thoughts. Also, avoidance of places or situations that may trigger these obsessive thoughts in the first place. Emotional characteristics then, anxiety and distress. So obsessive thoughts are unpleasant and frightening, which may lead to anxiety, which can be overwhelming. They may also have accompanying depression. So OCD is generally accompanied by depression, and anxiety can be accompanied by low mood and a lack of enjoyment. Also, they may experience a feeling of guilt and disgust, which may be directed at something external like dirt or at themselves. The cognitive characteristic then, so obsessive thoughts are thought to have occurred over and over and over again. They vary from person to person, but they're generally always unpleasant. And they have insight into excessive anxiety. So they are aware that their obsessions and compulsions are irrational, but they experience catastrophic thoughts about the worst case scenario, and they tend to be hypervigilant. So they maintain a constant alertness to keep attention to potential hazards. So how can the biological approach explain OCD? So it sees psychopathology as being caused by abnormal biological processes. So in OCD, we need to be aware of the genetic explanation and neural explanation. Neural explanation can be further divided into neurotransmitters and brain structure. So genetics. So there does seem to be evidence that there is a genetic link. So 37% of patients with OCD had parents with OCD. There's also a concordance rate of 21% if a sibling has OCD, which suggests it does run in families. They've also identified a gene that may make you vulnerable to OCD. So for example, the SERT gene, which affects the transport of serotonin, creating lower levels of serotonin. So it's found that in 2 unrelated families, 6 of the 7 family members had OCD. They also had this gene. It also appears to be polygenic. That means there is not a single gene that is involved in the development of OCD, but it tends to be that there are multiple genes that may cause OCD. So there's some evidence that there could be 230 different genes that may be involved in the development of OCD. So evaluation, we have supporting evidence. So Billett did a meta-analysis of twin studies, and they found that monozygotic twins had a concordance rate of 68% in comparison to 31% for dizygotic twins. So remember that monozygotic twins, so MZ twins, are identical twins. They share 100% of their DNA, whereas dizygotic twins are just siblings that have been born at the same time. They share 50% of their DNA. So the fact that those identical twins have a higher concordance rate suggests that it is genetics. However, there's a methodological problem with twin and family studies in that they share the same environment. Also, MZ twins, because they are identical, they're more likely to be treated more similarly. Therefore, it could be actual environmental factors that could be causing this and could be an extraneous variable. So neural explanation, so serotonin. So the neurotransmitter serotonin is believed to be regulated with mood. So low levels of serotonin have been linked to OCD. So it's based on the findings from antidepressant drugs. So when levels of serotonin have been increased, the symptoms of OCD have been reduced. Whereas antidepressants that have less effect on serotonin do not reduce OCD levels. So let's look at the evaluation. There is effective treatment. So SSRIs, which increase the levels of serotonin, can reduce the symptoms of OCD in 50 to 60% of cases, suggesting there is a link between OCD and serotonin. However, we can't establish cause and effect. Just because there's a link doesn't show the causal relationship. It could be that low levels of serotonin are actually the result of having OCD rather than the cause. Also, we need to be aware of the brain structure. So several areas of the frontal lobes of the brains are thought to be abnormal in patients with OCD. So particularly in the basal ganglia. So the caudate nucleus deals with our worries, and if it fails to suppress any minor worries, it means that our thalamus is alerted to things that are worrying and potential germ hazards, even if they are not. So there's supporting evidence for this. So Max et al. Found increased rates of OCD in people with head injuries that caused damage to the basal ganglia, suggesting that the basal ganglia does play a role in the development of OCD. However, there is contradictory evidence. Arwood didn't find a significant difference in the basal ganglia impairment between patients with OCDs and those who were controls. So that suggests that there isn't the sole cause of OCD. Biological treatments then for OCD. Biological treatments refer to drug therapy, so often chemicals that have an effect on the brain functioning. And because OCD is associated with low levels of serotonin, drug therapies work in different ways to increase the levels of serotonin in the brain. So we need to be aware of SSRIs, tricyclics and benzodiazepines. So SSRIs are the most common drug for OCD. So they block the reuptake of serotonin, therefore they increase the serotonin concentration within the synapse, so effectively increasing the level of serotonin in the synapse, and they continue to stimulate the postsynaptic neuron. Tricyclics block the transporter mechanisms that reabsorb both serotonin and noradrenaline. So as a result, more of these neurotransmitters are left within the synapse, effectively increasing the levels of serotonin and noradrenaline. Benzodiazepines, so BZs, they enhance the activity of GABA, which has a quieting effect on the brain's neuron. It makes it harder for neurons to be stimulated by other neurotransmitters, so the neuron's activity is slowed down, so it makes the patient feel more relaxed. So this one isn't necessarily increasing the levels of serotonin, but is dealing with the anxiety that is associated with OCD. So BZs are an anti-anxiety drug. So they are an effective treatment. So in a review of 17 studies that used SSRIs, so selective serotonin reuptake inhibitors, they found them to be more effective than placebos in reducing the symptoms, suggesting they are effective. They are relatively cheap and easy to use, so they require little effort from the user in comparison to other therapies such as CBT and psychoanalysis, and therefore it would be an effective and appropriate treatment. Also, from the health services point of view, they're cheaper because they don't require as much monitoring in comparison to psychological treatments. However, they don't seem to offer a long-term cure. So generally when people stop taking the medication, they relapse within a few weeks, suggesting they're not an effective form of treatment. So they're merely dealing with the symptoms, not the cause. Also, they have side effects. So nausea, headaches and insomnia are common side effects. So therefore, it might make the patient more likely to stop taking the drugs. So therefore, it's not an effective or appropriate form of treatment. Also, the evidence collected on drug therapy might be unreliable. So some psychologists argue that the evidence for drug treatment is biased because the research is sponsored by the drug companies themselves, who do not report all the evidence. Also, with the biological approach, it is very reductionist. It isn't considering any other explanation.